To begin this IC on pediatric ocular tumors, I'll be talking about orbital tumors in children, and this is a topic very difficult to cover in 10 minutes. So I'll just stick to some common scenarios and few uncommon scenarios that we see in the clinics. So we all know the classification. It can arise from any structure in the orbit, right from the blood vessels, from the glandular structures, muscles, and these are the kind of lesions that we commonly see, the benign ones, the dermoid cyst, the external ones, which could be in any location, the external angular being the commonest one. It can be internal angular, can be in the inferior orbit. Sometimes it can be deep down into the orbit also. Usually taken out, treated by a simple surgical excision, and the external ones can easily be taken care of by a hidden incision, either by a lid crease or by a conjunctival approach. Sometimes even the simple dermoids can actually cause a little trouble for us and can present in a little unusual way. So this was a small child, and these are the pictures which has been captured by the parents, and all they noticed at birth was a small dimple which this baby had in the temporal part around the eye. It was asymptomatic for some time except for the small dimple, and then they noticed sometimes there used to be a little bit of discharge coming out from that small pit next to the eyebrow. As the child grew up, she started getting these repeated episodes of inflammation of the eyelids orbit, which were being treated as sometimes stye, preseptal cellulitis. Sometimes with this discharge in the eye was also treated as NLD block, congenital NLD block. Now, subsequently, this was the picture. That area, the skin around that small pit started breaking down after these repeated bouts of inflammation, and then she had this chronic discharge from that pit. So when we saw her, this is how she was. There was this cellulitis kind of picture, something like a small abscess around the temporal part of the eyelid, and this small pit was a small sinus, in fact, was visible with little ooze from that. So when we got the CT, this was what we saw. There was a visible bony abnormality here. It's almost like a fossa formation. And there was this cystic mass lesion in the lateral orbit. And we can see the small area of the bony discontinuity through which it was probably communicating in the temporal fossa. And that's how this small sinus had formed. And subsequently, when she got these inflammatory episodes, it actually increased in size. This was the imaging done during one of those episodes, showing an increased collection with a lot of inflammation in the temporal aspect. And here we can see the small bony defect very clearly. So this was something like what we call as a double variety of dermoid, where sometimes we don't see a very obvious mass lesion like a cystic lesion, which is the typical imaging appearance, but the patient can actually present with repeated bouts of inflammation with subsequent fistula formation. This was another patient who had been treated elsewhere once, excision was done, but subsequently he started having this repeated inflammation from the skin and this small oozing discharge. So this was a residual dermoid, which probably part of it, the part which was inside the orbit was left behind. And that's what caused this recurrent inflammation. Now, an MRI was initially done for this patient. This was the pre-op MRI before the initial excision. And we can see this cystic lesion very nicely, superficial one. But what we cannot see here is the bony defect, the involvement of the bone. And the dumbbell can be missed. The part which is extending into the bone can be missed if we just rely on an MRI. So CT could be a better imaging modality in this situation, where it can show us the situation, what is going on inside a little better. Some more rare presentations where repeated bouts of inflammation from the dermoid can also cause cicatricial changes of the eyelid with cicatricial lag of thalamus, sometimes ectropion, and this patient needs to be, this abnormality also needs to be corrected along with excision of the dermoid, like in this patient. So these are the intraosseous dermoid. So this child was referred to us with a diagnosis of an orbital retinoblastoma, but if we see this eye, this actually looks like an orbital mass with a lot of conjunctival inflammation, hemorrhage, bleed, crust, erosion. But if we see the other eye, we know what the diagnosis is. So this is a microphthalmus in the right eye with a probably a clinical anophthalmos eye in the left side with an orbitopalpebral cyst, and the imaging clearly gives us the diagnosis. So many a time, because of the exposure, because of the conjunctival inflammation, they can mimic as orbital mass and sometimes can be misdiagnosed. A simple aspiration with a sclerotherapy with a sclerosing agent can actually take care of this pathology, and these patients subsequently can be fitted with a prosthetic eye. Now, hemangioma, we all know a lot about capillary hemangioma. The treatment has changed from intralesional steroid injection to excision to propranolol, now being the first line of treatment modality with very good response to treatment. We also now have several reports where efficacy of topical beta blockers has been shown to be very useful in this superficial lesions specifically. There are also reports of VEGF receptors being present in this orbital vascular malformation, and possibly there could be a role of anti-VEGFs in this patient, which we might know subsequently as more reports come up. Now, lymphatic malformations, sometimes they do present to us with an orbital cellulitis kind of picture, can get misdiagnosed as cellulitis, sometimes as orbital abscess. And imaging can give the diagnosis where we see a fairly well-defined sort of lesion with cystic or the collection inside, and rest of the orbit seems to be pretty quiet, which is unusual in cases of an orbital cellulitis with abscess. Aspiration will definitely give us a diagnosis, and again, sclerotherapy with various sclerosing agents works very well in this patient. There are again now reports of use of mTOR inhibitor, the sirolimus specifically, which are basically the VEGF and mTOR are the pathways which are involved in angiogenesis and lymphogenesis, and inhibiting those pathways can have a role in treatment of this patient. What we definitely know is the classification now, the new ISSVA classification, based on which we need to classify. And if we have to classify this lesion based on the ISSVA, we need to have the proper imaging modality. And for most of these patients, the best imaging modality remains a dynamic MRI, which can tell us whether it's essentially a venous or a lymphatic or a predominantly arterial sort of malformation. So it's important to distinguish between the two, because we know in a venous or a lymphatic venous malformation is the size of the outflow channel, which is the most important determinant of what imaging, what treatment modality we are going to choose, and what is going to be the prognosis. And in arterial is the size of the inflow and the needle size, which is the most important determinant. A Valsalva is a very useful test which can give us some idea about the outflow channel, and a definite increase in Valsalva, like in this patient, is an indicator that there is going to be a definite big feeder channel behind, and that needs to be taken care of. And the simple sclerotherapy with a direct injection into the lesion without any guidance might not be a very good option. Now, while we're talking about this vascular malformation, which can sometimes present with bleed, this was one child who came to us, this was sometime last year during the lockdown period, with this lot of bleeding around the periorbital area, a lot of necrosis of the eyelid skin, massive proptosis, the eye was sort of a non-seeing eye. And initially, the initial blood investigation did show thrombocytopenia. So we initially thought it could be an ITP, sort of some vascular, sort of, hematological sort of abnormality. Since rest of the things were parameters were normal, just thrombocytopenia, we thought it could be a bleed associated with a thrombocytopenia kind of thing. And his imaging did show this fairly well-defined anterior orbital mass lesion, which was enhancing very nicely with contrast. However, since he was not improving the conventional treatment, and subsequent imaging with a PET CT showed some other lesion in the lungs and the lymph nodes, we went ahead with a biopsy, and biopsy showed small round cells. And these were the immunomarkers, positive for CD3, 45, 99, which ultimately was suggestive of a diagnosis of NK T-cell non-Hodgkin's lymphoma. So, and T-cell lymphomas, especially the NK cells lymphomas, are very unusual in the orbit. Mostly what we saw, and especially in children, are the, though it's very rare, lymphomas are not very common in children, but what we saw are mostly the B-cell ones. So now this patient did respond to the chemotherapy regime. The eye did respond well, but subsequently he landed up with a relapse, the vitreous relapse in the other eye, and this skin lesion then started coming up of the cutaneous lymphoma, and finally he actually succumbed to the disease. We could not the treatment was not effective. So these patients do carry a very poor prognosis. They're aggressive tumors, and we need to know that sometimes they can present with a cellulitis, inflammation, or a hemorrhage kind of picture, and we need to have a very high suspicion, do biopsy wherever required. And these are not simply hemorrhage, orbital hemorrhage, though sometimes they can present with thrombocytopenia and other blood abnormality. Another patient was initially diagnosed as a conjunctivochalasis, was being treated somewhere else with topical steroid lubricants for some time, did not subside, worsened. This was the picture when we saw her, a lot of thickening on the conjunctiva. This was definitely not a conjunctival calluses or an inflammation of the conjunctiva, which usually does not happen in a child, especially unilateral. And biopsy gave us the diagnosis. The blast cells, which we could see even in the incision biopsy specimen, and subsequently even on the peripheral smear, we could see the blood cells. So this was an acute lymphoblastic leukemia, lymphoma, what we call them, which presented as a conjunctivitis, unusual. So, Feroz, do I have time or should I stop?
SIMA, we have time.
Okay.
How's to be started? So we can.
Yes, 2 minutes more? Yeah, 2 minutes.
Go ahead.
So leukemia commonly presents with this kind of picture, rapidly progressing proptosis, but many a times it could be a little atypical presentation, like in this child, presenting like a sino-orbital mass, and the initial peripheral smear did not show anything, but subsequent biopsy did pick up the diagnosis of the leukemia. Another patient presenting with a lacrimal gland mass, which we thought could be a lacrimal gland tumor, and we know that ACC can present in a younger age group, but since the suspicion was little high and this was rapidly progressing, we initially did a peripheral smear and it actually picked up the blast cells, and subsequently was diagnosed as an acute myeloid leukemia, and she is currently in remission, and this is the current picture. Now, just 2 more cases of fungating mass. When you talk of fungating mass, this is the picture we very commonly see, and we all know what it is: orbital retinoblastoma presenting with a fungating mass. A similar child, again, we saw in the last year presenting with a fungating orbital mass. The initial impression looks like an orbital RB, but when we did the imaging, we see that there is nothing in the globe. It's essentially an orbital mass. Now, this is what we saw in biopsy. Alveolar sort of pattern with a lot of loose myxoid stroma, and the immuno which was done was positive for SALL4 and AFP, alpha fetoprotein, and we know that with these immunomarkers they are very, very diagnostic of AIOC tumor. But what was surprising was that she did not have any other systemic abnormality. Her systemic workup did not show anything in the abdomen, and it was ultimately diagnosed as a primary orbital AIOC tumor, where very few cases are reported in the literature. The response to the chemo is very good in these patients. As we see here, it almost resolved completely the orbital mass, and 1 year down the follow-up, this is what her picture is. Another fungating orbital mass. So again, this is not a retinoblastoma as we see here, and what the imaging is very, very unusual, a solid component along with a huge cystic component. But the solid component, the shape is something what we know that could be there in other tumor, that is an optic nerve glioma. So in this patient, we aspirated the cystic contents and also did an incision biopsy, and on the squash imprint slide, this is what we saw: the fusiform cigar-shaped cells with cytoplasmic processes, the dendritic-like cytoplasmic processes, which was quite diagnostic of an optic nerve glioma, a low-grade one. So normally gliomas present like this, but unusual presentation like a fungating mass with a lot of cystic degeneration can also be there. This is how we commonly see the Ewing's PNAT, primarily a bone-based tumor with a lot of bone destruction with an orbital involvement. Maxillary area is commonly involved, but this was another child we very recently saw with a little bit of maxillary fullness here, inferior orbital mass lesion with a temporal mass lesion, imaging showing a triradiate kind of picture, but there was involvement of the maxilla. This is little inferior, not superior like we see the classical triradiate involving the sphenoid bone. And I don't have the histopathy yet for this child, but on incision biopsy, it showed a malignant round cell tumor, which were positive for NSE, CD56, synaptophysin, and CGA, which are kind of, confirms the diagnosis of a neuroblastoma. Again, what was unusual was that this child did not have anything else on systemic workup. Abdomen was clear, which is very, very unusual. Normally, this is how we see neuroblastomas, the raccoon eyes that we call bilateral periorbital ecchymosis, bilateral orbital masses. The triradiates are quite common, but sometimes we can see a quite orbital mass unilateral without systemic involvement like we saw in this child. So this was what was about some common and some uncommon orbital tumors in children. Thanks. Thank you.
Thank you very much, Dr. SIMA. That was an excellent